Welcome, future colleagues, to this explainer. Okay, let's just dive straight in and see if you can instantly spot the trap in a classic clinical vignette. We're going to completely deconstruct a really high-yield medical topic today, one that examiners absolutely love to test. And by the end of our time together, you're going to have a razor-sharp mental model to conquer it.
So, think about this. What demyelinating disease produces both upper and lower motor neuron signs simultaneously? Recognizing this duality is absolutely crucial. It's the absolute key to mastering metachromatic leukodystrophy, or MLD. It's a lysosomal storage disorder that gives you a single patient with findings from both of these compartments. Spotting this specific combination should immediately narrow down your differential, the very second you see it in a case study.
Here's a quick look at our agenda. We'll start with biochemistry and clinical timelines, uncover that crucial UMN/LMN signature, review diagnostics and management, and then finish up with the ultimate leukodystrophy differentiators. We're building this whole framework around the 6 biggest exam traps, so you literally never miss these questions again.
Okay, Section 1, Biochemistry and the Illusion of Enzymes.
Let's start with the basics. MLD is an autosomal recessive disorder, and it's caused by a deficiency of aryl sulfatase A, or ASRA, which is encoded way over on chromosome 22 Q13.33. Now, this enzyme is super important because it desulfates a major lipid component of myelin. When it's deficient, sulfatides just progressively build up, inside oligodendrocytes, Schwann cells, macrophages, you name it. But here is the illusion, and exam trap number 1. Pseudo-deficiency of aryl sulfatase A. This is just a benign polymorphism. It gives you a low enzyme reading in the lab, sure, but the actual person, clinically, they are completely normal. Examiners will deliberately bait you with this. They'll throw you a vignette with low ASRA activity, but 0 clinical findings, just to see if you reflexively diagnose MLD based on that lab value alone. Don't fall for it. Always correlate the assay with the patient sitting right in front of you.
And this actually illustrates the inverse trap brilliantly. What if your vignette describes classic MLD features? Elevated sulfatides, widespread demyelination, but the aryl sulfatase A enzyme activity is completely normal. Do you just rule out MLD? No way. You've got to suspect saposin B deficiency. Saposin B is a sulfatide activator protein, and if a patient lacks it, it produces the exact same biochemical and clinical phenotype, just with perfectly normal ARSA levels. It's a tricky one for sure.
Moving on to Section 2, Clinical Timelines. Let's look at how the age of onset totally dictates the presentation.
So the way this disease presents is entirely dictated by residual enzyme activity, and that creates 3 main presentations based on age. The late infantile form is the most common. That hits between 6 months and 2 years, with gait issues, hypotonia that eventually evolves into spasticity, and a really rapid progression. Then you have the adult form, presenting after age 16 with cognitive decline and psychiatric symptoms. But put your vignette vision on for a second. Here's exam trap number 2. Look closely at that juvenile form in the middle. A kid between 3 and 16 with a sudden drop in school performance and new onset behavioral changes, that is testing the juvenile presentation of MLD, not some primary psychiatric or purely behavioral issue. Don't anchor exclusively on the infantile form when leukodystrophies are on the table.
Section 3. The UMN/LMN signature. Pay attention because this is our highest yield discriminator. This is where we lock in the absolute defining feature of metachromatic leukodystrophy, dual compartment demyelination. Because that sulfatide is accumulating in both the central white matter and the peripheral nerve myelin, patients show this incredible combined picture. Central demyelination gives you upper motor neuron signs. So think spasticity, brisk reflexes in certain segments, maybe extensor plantar responses. But at the exact same time, peripheral demyelinating neuropathy gives you lower motor neuron signs, specifically diminished or completely absent deep tendon reflexes at the ankles. So the crucial takeaway here, and exam trap number 3, is this. Spasticity plus absent ankle reflexes, that means MLD or Krabbe disease. It completely, 100% rules out the purely central leukodystrophies.
All right, Section 4, Diagnostics and Visualizing the Clues. To actually prove what we suspect from the clinical exam, you look at the MRI. You're searching for symmetric, confluent, periventricular white matter changes. These often have this distinct, radiating striped appearance because the perivascular areas are spared. Plus, nerve conduction studies are going to definitively show reduced motor and sensory conduction velocities, which confirms that peripheral neuropathy component we just talked about. This leads right into our diagnostic algorithm. First, start with urinary sulfatide quantification. That's going to be elevated. Next, run the enzyme assay for ARSA, but keep that pseudodeficiency trap we discussed in the back of your mind. Step 3 is genetic testing for the ARSA gene mutation. That is your definitive confirmation, especially when enzyme results are kind of ambiguous, or if you suspect sapacin B. And historically, step 4 was a peripheral nerve biopsy.
And hey, speaking of that biopsy, this brings us perfectly to exam trap number 4, the etymology question. When you take that accumulated sulfamipatide and stain it with aniline dyes, like toluidine blue or crescel violet, instead of getting the expected blue color, you get this really unique golden ground color shift. This specific histochemical finding, those metachromatic granules, that is literally where the disease gets its entire name.
Section 5, let's talk management facts, specifically the truths about HSCT and gene therapy.
So while care is mostly supportive, managing spasticity, seizures, nutrition, we do need to quickly cover the major disease-modifying options. First step is hematopoietic stem cell transplantation, or HSCT. Watch out for exam trap number 5 right here. HSCT primarily just halts or slows further progression by supplying enzyme-competent donor cells. It does not, I repeat, does not reverse established neurological damage. Timing is literally everything. It's way more effective when performed pre-symptomatically or in early symptomatic, slowly progressive cases. It's unfortunately far less effective in the rapidly progressive late infantile form.
Now, examiners also really love testing your current awareness, so you definitely need to note this massive gene therapy breakthrough. It's called atidarsagonine auto-TEM-cell. It's an ex vivo lentiviral gene therapy that delivers functional ARSA using autologous stem cells. And just like HSCT, it is approved for pre-symptomatic or early symptomatic patients. Definitely keep this in your back pocket for those cutting-edge management questions.
Section 6, the Leukodystrophy differentiators. This is pretty much the holy grail cheat sheet of our explainer. It'll differentiate MLD from the rest of the pack so you never get confused on exam day. I want you to mentally photograph this comparative table. It will visually resolve almost every single leukodystrophy comparison question you're ever going to face. Notice MLD paired with ARSA and those mixed UMN-LMN signs. Then you've got CRABE with GLC, extreme irritability in globoid cells. X-linked ALD features ABCD1 and adrenal insufficiency. And Pelizaeus Merzbacher disease links with PLP1 and a classic tigroid pattern. But I want you to look really closely at that peripheral neuropathy row. See, this brings us to exam trap number 6. Why do MLD and CRABE stand out from the rest? It's because only MLD and CRABE involve the direct breakdown of peripheral Schwann cell myelin. That's what causes the significant peripheral neuropathy. ALD and PMD, on the other hand, they are classically restricted solely to the central nervous system. This single, simple discriminator instantly separates your multiple choice options. It's a real game changer. Okay, let's head into our final section, the rapid-fire MCQ drill. Let's lock this knowledge in with a quick drill based strictly on the examiner traps we just covered. Try to answer these in your head before I do. Ready? Question 1. A 14-month-old has progressive gait disturbance, spasticity, extensor plantar responses, and absent ankle reflexes. Diagnosis? Bam! It's MLD, or CRABE as a key differential. You can diagnose this instantly because of those dual central signs, the spasticity and extensor plantars, paired with the peripheral nervous system signs, those absent ankle reflexes.
Question 2. You see low aerosulfatase A activity on an enzyme assay, but there is no clinical or radiological evidence of disease. What's the best next step? You've absolutely got to confirm with urinary sulfatides or genetic testing to rule out a pseudodeficiency allele. Never ever diagnose based on the lab number alone if the patient looks completely fine.
All right, question 3. You have a classic MLD clinical and biochemical presentation. So elevated sulfatides, demyelination, but the aryl sulfatase A activity is totally normal. Likely diagnosis, remember that highly testable variant we talked about? Sapacin B deficiency. They're missing that critical sulfatide activator protein.
Question 4. Which two leukodystrophies characteristically produce peripheral neuropathy, and why? That would be MLD and CRABE disease, because both of them directly involve the breakdown of peripheral Schwann cell myelin. That separates them from all the purely central leukodystrophies.
Final question for you. If you see spasticity and absent ankle reflexes on your next exam vignette, are you ready to dodge the trap? Anchor your revision on this unique clinical signature, future colleagues. Just remember the mixed upper and lower motor neuron signs, the whole pseudodeficiency illusion, and the peripheral neuropathy discriminator. If you master these, you completely master the topic. Keep learning, stay focused, and I will see you in our next explainer.